Hey everybody, a quick note about our precision medicine training program. It's been a really popular course. We're constantly hiring health coaches and physicians, but we're only hiring them as we grow if they're trained in precision medicine. You don't get that in medical school or other places. And so we've developed this training program and we've completely revamped it recently. It's a lot more robust. So now there's still over 50 hours of live synchronous training. There's also all the asynchronous credit, over 50 hours of content. And as a physician, you get about 50 hours of AMA Category 1 CME credit, which is a nice benefit. For the health coaches going through the training program, it's now accredited by the National Board of Health and Wellness Coaching. So graduates are going to meet the requirement to sit for the board exam and become board certified health coaches. So there's a lot of benefits to that, not just the certification, but also when it comes to things like insurance reimbursement. So it's a really robust program. If you're a physician, a nurse practitioner, a PA, or someone that just wants to be a health coach, it's open to all of those categories. There's the 6-month program that's kind of the full program. And then we also have just a fundamentals of precision medicine course, which is completely on your own. It's online. It's all asynchronous. You still get the 50 hours of AMA Category 1, but it's self-paced. And you still have access to the online community, but not all the synchronous lectures as well. So if you're interested in checking that out, go to wildhealth.com/education, and we'd love to have you as part of our next class.
Hey, Trey. How's it going, buddy?
Good, Mike. How are you today?
I am surviving dreary, rainy Portland weather, but warm and inside and ready to talk about insulin resistance. How about you?
Yeah, same. It's nice and chilly out here in the spring in Kentucky.
All right. Well, we did a pretty deep dive on continuous glucose monitoring not that long ago, and we wanted to follow it up with a bit of more detailed discussion on insulin resistance, because we talk about this concept of insulin resistance and this phenomenon of insulin resistance and how it increases our risk of a number of different chronic medical conditions. And it comes up a fair amount, but we haven't really done a bit of a, insulin resistance in a nutshell podcast. So figured it would be worthwhile to dive in. The one thing I want to get out of the way is you and I laughed about this. We did this podcast on CGMs, and then almost immediately after we hit stop on the recording, we came across a study on CGMs that we didn't discuss. So just for the sake of kind of putting a period at the end of that sentence, studies called Susceptibility of Interstitial Continuous Glucose Monitor Performance to Sleeping Position. And this is not new. This is from the Journal of Diabetes and Scientific Technology 2013. But the take-home point is, if you sleep on top of your continuous glucose monitor, you can get some faulty low readings that are not actually representative of your capillary or your interstitial glucose. So if it's on your left tricep area and you're a left-sided sleeper, beware.
Yeah, you'll see that too occasionally, just in practice. If you're wearing it and you are sleeping on your side and lying there, you'll see a low glucose notification through the night. It can be concerning for some folks, but that paper and that knowledge is useful, especially if you're a side liar laying on your glucose monitor.
Yeah, I don't know that I know which side I sleep on, but I guess if you know you're like a left side sleeper, maybe put it on your right arm. That'd be the take-home pro tip for your continuous glucose monitor. In my case, I think I kind of hit sides, belly, back all through the night. All right, off to insulin resistance. Boil it down for me. If you're explaining insulin resistance to one of our patients and you're trying to make it digestible but also relevant, what's your spiel?
Yeah, so I usually go through and kind of break down the difference in type 1 and type 2 diabetes depending on the individual's prior knowledge level. But here we're talking specifically about insulin resistance in the setting of no childhood onset type 1 diabetes. So the body is just, the cells in the body are becoming less sensitive to insulin, which is a hormone produced by the pancreas. That insulin hormone helps regulate blood sugar levels. And as the body becomes less sensitive over time, it requires more insulin to achieve that same desired effect of keeping glucose levels down to a normal level. For that reason, oftentimes you'll see elevated fasting insulin prior to seeing an elevated hemoglobin A1C, which is a 3-month average of your blood glucose. That's at the very beginning onset of insulin resistance.
And, we know there are a bunch of factors that can contribute to the development of insulin resistance. In the US, I think obesity has got to be top of that list, since excess body fat interferes with insulin signaling pathways and can lead to decreased insulin sensitivity. Diet, sedentary lifestyle, depending on genetics, a high saturated fat diet can certainly increase your risk of developing insulin resistance. And trans fats, which I think are kind of phasing out. Trans fats are sort of the cigarettes of the 2020s. I feel like more regulation, more knowledge around the fact that it's that those are harmful, and just a general standard American diet that's low in fiber. All of those things can increase your risk of insulin resistance. Other factors that we're not mentioning?
Yeah. I think you look at, I think we mentioned this on the CGM podcast, but if you look at stress and cortisol levels, or what a high stress day does to your glucose level, and we talked about how that impact kind of plays out. But actually stress pushing up hemoglobin A1C over time under stressful conditions. Cortisol essentially provides the body with glucose, right? So if you're in a fight or flight response, the body taps into protein stores via gluconeogenesis, produces glycogen from the liver, which elevates blood glucose. And that allows the body to have that extra immediate energy that's needed in an emergency situation. However, if we're responding to mental stressors in that way, that elevated cortisol level over a long period of time can consistently elevate glucose levels and increase average blood sugar levels to the point that we start to experience insulin resistance.
And, I think that's a good summary of sort of the broad relevant issues with regards to insulin resistance. If we wanted to take a little bit of a deeper dive, what's happening at the cellular level? Like what's actually really going on that's leading our bodies to not react to insulin the right way and to not respond to insulin the right way?
Mm-hmm. Yeah, that's a $1 million question, really. It's a pretty complex network of molecular pathways, as well. So it includes the insulin receptors as well as some downstream signaling molecules. And, generally insulin binds to the receptor on the surface of the target cell, which, has that cell uptake glucose. And then it activates a cascade of intracellular signaling pathways to get there. Glucose is taken up. It also, those pathways impact glycogen synthesis, which again is what the liver stores glucose as and then releases that into the bloodstream. And then also those pathways that are involved in insulin resistance or sensitivity impact the way lipids are metabolized. So in insulin resistant individuals, these pathways have become impaired, one or all of them to some extent. That could either be at the insulin receptor site. It could be through those intracellular signaling pathways. There could be deficits there. So, again, abnormalities that mediate glucose uptake, glycogen synthesis, or lipid metabolism. And then we talked about chronic inflammation. That actually does impact the intracellular signaling pathways that we kind of spoke of through that mechanism of cortisol. Lipid accumulation in and of itself, so excessive accumulation of lipids in the liver and skeletal muscle can interfere with insulin signaling and lead to insulin resistance. And then probably a little bit nerdy, if none of this already was, is mitochondrial dysfunction. So the mitochondria are known as the kind of powerhouse of the cell or the muscles, and they're responsible for producing ATP. In general, though, mitochondrial dysfunction as an isolated issue can lead to decreased beta oxidization, which is a metabolic process involving multiple steps where fatty acids are broken down to produce energy. So that's impaired. ATP production is impaired during mitochondrial dysfunction. And then that increases reactive oxygen species, increases inflammation, and that leads to insulin resistance, or diabetes, or cardiovascular disease. So, quite the complex process there, Mike, but a lot of different things involved. Essentially kind of coming back to the main reasons that insulin resistance is a problem. It's either nutritional, dietary, movement, and we'll kind of get into some of the more of those causes and what leads to that.
Yeah, I mean, it was sort of a stumper question that you handled excellently, because the reality is there's still a lot being discovered about the actual mechanism of insulin resistance. And there's many theories out there. Some of them are, the traditional one is sort of this lock and key theory where you've got insulin that's supposed to fit into the insulin receptor, and there's something wrong with the receptor, or there's something wrong with the insulin and it's just not fitting in the right way. It's certainly not that simple. There's theories around total body glucose levels being out of whack and that really leading to insulin resistance. So at the end of the day, we can say with confidence that there's multiple factors involved, that the relative contribution of those factors is still being elucidated and may differ between one person and another person. So if we're going to go into practical things that we can take away and apply to our patient care and give our patients advice on, that we can feel confident about, we do know, and we touched on this in the CGM podcast, so I'm not going to go into detail here, but we do know that glycemic variability, the degree of variation in our plasma glucose levels over time, is an independent risk factor for cardiovascular complications and all-cause mortality. So we don't want to be having big spikes, big drops. We want to be maintaining a pretty steady level of glucose in a normal range, and that's ideal. Now, that sounds great, but how do we actually do that? We talked a bunch about nutrition and avoiding naked carbs. We talked about glycemic index. Talk to me a little bit about sleep, which I don't think we touched on, and the relationship that sleep can have to avoiding glucose variability and helping to prevent or to improve insulin resistance.
Yeah, I guess there's really two ways to think about this. You could talk about how adequate or regular sleep would improve glucose variability and insulin resistance, but you could also talk about how multiple factors lead into whether sleep is in an optimal state, right? So they both kind of feed into one another. So whenever I think about sleep and your circadian clock, for example, you really want to support that through all the factors that impact it. You want your circadian rhythm to know what time it is, and you want to be consistent in the factors that impact whether that is in a nice rhythm for you. So if you think about the factors that lead into your circadian rhythm, you're looking at things like light exposure. You can look at light exposure in the morning and then in the afternoon. That impacts the way the body is able to determine what time it is, and melatonin production as well as cortisol production early in the morning. Those things being important, as we've talked about, the way that cortisol impacts the body's uptake of insulin. Food intake timing also impacts the circadian rhythm. So that's another external factor, as well as what time you wake up, and physical activity, especially in the morning, helps the body know what time it is and starts the production of a lot of the hormones and neurotransmitters that are important for the body whenever it's looking to uptake nutrients and as well as getting adequate sleep. Again, all these factors lead to your body having a central clock that knows what time it is. Those two factors are melatonin production in the evening and cortisol production in the morning. In turn, that internal clock has outputs that impact your hormone regulation, as well as the peripheral clocks in the body. So the physiologic responses to nutrients and hormones. So all those factors lead together to say that if you can be consistent around your sleep and do the things that will help your body understand what time it is, the nutrient uptake and insulin sensitivity will improve. Plus, good sleep will also help the body to use nutrients more efficiently. It impacts the amount of hormones secreted and the ability to build muscle and so on and so forth.
All right. So definitely thinking of circadian rhythm as tied to insulin resistance, not something that comes immediately to mind, I think, for folks as an obvious correlation, but definitely our insulin hormone secretion is tied to our circadian rhythms. This is sort of why you hear folks often talk about, pushing calories and particularly pushing carbs towards the beginning of the day when we're much more insulin sensitive, and avoiding big, heavy nighttime meals and nighttime carbohydrate intake for the same reason. All right. So we know about nutrition. We talked about it. We're not going to go there again. Talked about sleep and the importance of synchronizing our circadian rhythms. Ironic that we're doing this podcast today after we just had daylight savings time, and neither of us have really synchronized circadian rhythms at the moment, but we're going to work on that. Movement. Obviously, we've talked about the importance of movement and metabolic flexibility, both on the CGM podcast and in other podcasts. I'll just summarize quickly. Post-meal or post-prandial movement is really key. This is advice that's been out there and endorsed by the American Diabetes Association for years and years. And yet, I think of all the sort of standard health tips that you see popping up in clickbait and circulated on blogs and news feeds, it's amazing to me this isn't emphasized more. So getting out and doing a 20 or 30 minute walk after a meal has really just tremendous impacts on our ability to be insulin sensitive and to keep those glucose spikes down. Incorporating things like high intensity interval training, fasted zone 2 exercise, and then just making sure that you're doing some degree of resistance training to grow or at least maintain lean muscle mass. All of those things are going to make you more metabolically flexible and less likely to be insulin resistant. We talk about genetics a fair amount. I don't think we need to go full nerd and get into the details of all of the SNPs that can impact your polygenomic risk scores and risk of insulin resistance. I think I'll summarize here for us and just say, we look at a bunch of these: PPAR alpha, multiple FTO SNPs, GIPR. There are reasons why certain individuals are more sensitive to things like dietary saturated fat, for example, that can lead to an increased risk for developing insulin resistance. So certainly if you have your genetics or you're working with a provider, that's something to look into, because that may have downstream effects on the recommendations in terms of macronutrients and food content that you're taking in. Similarly,
a bit of
go ahead, Trey.
Yeah, just a bit of practical advice. I wanted to go back really quickly to movement. You mentioned the post-meal movement or a post-meal walk. Something really interesting, if any of our listeners are using a CGM, is to do like 20 squats, 20 burpees, or whatever you're capable of prior to a meal, and watch and see how that impacts your glycemic variability. So movement before meals can be really effective in kind of priming that muscle for glucose uptake. And it's just a little bit of an interesting kind of caveat to the post-meal movement, which is very effective.
Yeah, I love that. And, it ties back into one of the most fun things, I think, about using a CGM is being able to do those little mini experiments of, I'm going to eat the same dinner twice in a week, at least in my house. I'm probably going to eat it maybe 3 times in a week. So I have a lot of control over being able to modify other factors around the meal to see what kind of impact that same meal has on my glucose behavior. In terms of measures and what we look at for insulin resistance, I think we touched on all of these. Just summarizing quickly: hemoglobin A1C, it's not a perfect measure, but it does tend to give us a general sense of what the average of our blood glucose has looked like over the last several months prior to testing. In the US, we're really looking for under 5.7 is considered normal. 5.7 to 6.5 is considered pre-diabetic, and over 6.5 considered diabetic. Those recommendations change from country to country, and certainly I think our approach is that there's normal and then there's optimal. So being below 5.7, I think it does say something about your metabolic health if you're 5.6 as opposed to 4.9. And certainly we're looking to get people down into the high 4s, very low 5s for an ideal optimal target. Fasting glucose, really not that useful isolated unless it's elevated. So, if you have a fasting glucose of 95, you may still have some early insulin resistance. As you alluded to, we'll see our fasting insulin levels rise before we see our fasting glucose levels rise. So certainly if you're able to get your fasting insulin checked, that may give you some early insight. And then, not to beat a dead horse, but CGMs, as opposed to getting one measurement of your glucose in the morning fasted, getting a sense of what your sugar does over the course of a day in real time is a great measure to look at as well. All right, so let's say that we're working with somebody, Trey, and they've got a hemoglobin A1C of 5.6. They're kind of creeping up towards prediabetes, but they're not technically in the range of prediabetes yet. Their fasting glucose was 99 milligrams per deciliter, so still technically normal, but right up there. Their fasting insulin was 6.5. We want to see that below 5, so that's kind of on the high side. And we have them play around with the CGM for a couple of weeks, and we see that they're definitely having some prolonged spikes, postprandial spikes. They're also just kind of running in that kind of mid 90s to low 100s as their baseline glucose over the course of the day. If you had to pick 5 or 6 interventions that you would recommend for that person, what would those be?
Yeah, there are probably 5 or 6 just standard recommendations that fit well for everyone. And I'll go through those in just a second, but there are a couple factors that impact your decision here. Is it male or female? And then also their prior activity level and how long they're feeding. So are they already practicing time restricted feeding just naturally, or have they been doing that for a while, or are they eating, breakfast till bedtime? So, keeping those things in mind as they impact the decision-making process, but just in general, if the individual is overweight, weight loss, and then avoidance of the standard American diet, simple carbohydrates, processed foods, we really want to go ahead and cut those out. Movement, just movement in general, progressing into exercise, and then trying to add lean muscle mass, as lean muscle mass we know is a really effective engine in using glucose. Increasing fiber in the diet to help, fiber reduces net carbs in general and can slow the absorption of some simple carbohydrates. We talked about specific time movements, postprandial or pre-meal movement is really effective. And then there are medications and supplements like berberine, fiber supplements, medications such as metformin, and then you go on down the list of more advanced medication treatment. And then last would be exogenous ketones, which I think we spoke a little bit about on the CGM podcast, but it's really interesting to see what giving the body that fat for fuel source does in the way of mitigating glycemic variability and just keeping that glucose level consistent during meals or during exercise as well.
Awesome. Well, I love it. Complex topic distilled in under 25 minutes into something that I think people can hopefully have a good global sense of the concepts that are relevant to insulin resistance, how we measure it, and what sorts of things we might want to adjust with regards to nutrients, nutrient timing, sleep, movement, medications, etc. Thanks again for doing this, Trey. I appreciate you.
Yeah. Thanks, Mike.
Thanks for listening to the Wild Health Podcast. If you found it helpful, give us a 5-star rating and write a review on iTunes. It really helps the podcast, and we greatly appreciate it. If you want to be a client or you want to work with us, go to wildhealth.com. Thanks again.